Welcome to Dr. Seven's channel. Today, we're diving into a brand new explainer, and we are mapping out the structural anatomy and honestly, the incredible clinical relevance of the human lower limb. Here's the game plan for this spatial descent. We're going to cover the pelvic girdle and hip, the anatomy of the thigh, the knee joint complex, the leg and ankle, foot arches and biomechanics, and finally, the development of the lower limb. All right, kicking things off with Section 1, the pelvic girdle and hip, we're starting right at the top. Just look at the incredible architecture here. You can clearly see how three distinct regions, the ilium up top, the ischium posteroinferiorly, and the pubis anteromedially, perfectly fused together. It's like a biological puzzle coming together to form this amazing cup-shaped cavity called the acetabulum, which gives a really robust multi-axial socket for the head of the femur. Now, seeing this on a radiograph really brings that multi-axial ball and socket joint to life. Notice how snugly the femoral head fits right into the acetabulum, completely supported by the femoral neck. I mean, that strong connection is absolutely crucial for everything we do, from just basic walking to full-on athletic jumping. So, anchoring our knowledge on that femoral neck, let's look at the clinical side of things. Normally, the femoral neck sits at a precise 125-degree angle to the shaft. But because it takes on so much stress and is a super common fracture site, any deviation from that normal angle causes real structural issues. If the angle abnormally increases, gets straighter, we call that coxa valga. If the angle decreases, it's coxa vara. Both of these will drastically alter your biomechanics and gait. It completely changes how you walk. Moving right along to Section 2, the anatomy of the thigh, specifically looking at those vascular and neural pathways. Okay, so the crucial thing when you're studying the thigh is understanding the femoral triangle, sitting just below the inguinal ligament. And the naval mnemonic is absolute magic for effortlessly remembering the lateral to medial order of the vital structures there. We go from the femoral nerve, to the artery, to the vein, through the empty space of the femoral canal, and finally hitting the lymphatics. Knowing this exact sequence is a literal lifesaver in clinical practice, especially if a physician needs to access the femoral artery without accidentally hitting the nerve. Speaking of those blood vessels, what actually happens when the venous return in the leg fails? Well, when superficial pathways like the great saphenous vein lose their elasticity, the valves become incompetent and blood just pools. That's what causes those bulging, painful varicose veins. But even scarier is thrombophlebitis. That's when a deep vein gets inflamed and a thrombus or clot actually forms. This is a severe clinical reality that can lead to a deadly pulmonary embolism if that clot breaks free and travels up to the lungs. Next up, Section 3, the knee joint complex. It is incredibly complex and bears a massive load. Now, to the untrained eye, the knee might just look like a simple hinge, but it's actually a highly complex condylar type of synovial joint between the femur and tibia, combined with a saddle joint for the kneecap or patella. Because it has to bear so much immense weight, the knee leans heavily on its condyles, those shock-absorbing menisci, and strong collateral ligaments to prevent any dangerous lateral or medial displacements. There's a wonderfully strange structure right here called the petis anserinus, which literally translates to goose foot. It's formed by the combined tendinous expansions of three muscles, the sartorius, the gracilis, and the semitendinosus, all attaching right at the medial tibia. The immense clinical value of this? Well, surgeons actually frequently use the semitendinosus tendon from this very spot to repair a torn ACL. It's kind of like nature provided us with our own built-in spare parts. Dropping further down, we hit Section 4, the leg and ankle, focusing on its dual bone structure. It is absolutely vital to understand the contrast between these two leg bones. The tibia is your heavy, primary weight-bearing pillar, and because it takes all your weight, it's unfortunately the most common long bone fracture site in the entire body. The fibula, on the other hand, just sits laterally and is entirely non-weight-bearing. It simply acts as a critical anchor point for your muscles and helps stabilize the outside of the ankle joint. Looking closely at the anterior muscle compartment of the leg, we have to talk about the clinical reality of compartment syndrome. You see, the deep fascia wrapping these muscles is incredibly tight and unforgiving. So if there's trauma, any severe fascial swelling literally has nowhere to go. The pressure rises and basically chokes off the blood supply from the anterior tibial artery. This can quickly lead to ischemic necrosis, which means the muscle tissue starts dying off. It is a true, undeniable medical emergency. As we reach the medial malleolus of the ankle, we find the tarsal tunnel, and this brings us to another classic medical mnemonic, Just remember Tom, Dick, and Harry to perfectly recall the exact anterior to posterior order of the structures pinned down by the flexor retinaculum. You've got the tibialis posterior, flexor digitorum longus, tibial artery and nerve, and the flexor hallucis longus. Super simple, highly memorable, and definitely a must-have for your clinical anatomy toolkit. All right, Section 5, Foot Arches and Biomechanics, the body's ultimate shock absorbers. Take a second to consider these amazing interlocking arches. We have the medial and lateral longitudinal arches, plus the transverse arch. They're maintained by specific keystone bones, like the head of the talus for the medial arch and the cuboid for the lateral arch, along with the tough plantar aponeurosis. Together, they don't just passively hold our weight up. They act as these powerful, dynamic springs that actually propel human locomotion. But what happens when those supportive structures fail under repetitive stress? Well, you get what's called a march fracture. It's a fatigue fracture that happens right in one of the metatarsal bones. We see this all the time in folks subjected to prolonged weight-bearing stress. Think long-distance walkers, military recruits on heavy marches, or even female ballet dancers who are repeatedly loading their full body weight right onto their toes. Another incredibly common clinical issue right at the big toe is gout. This is an excruciating joint inflammation caused by abnormal purine metabolism, which leads to sharp urate crystals being deposited right inside the synovial cavity. For reasons mostly tied to temperature and joint mechanics, it notoriously targets the metatarsal phalangeal joint of the big toe. It literally makes every single step agonizing for the patient. Finally, Section 6, the development of the lower limb. A quick look at our embryological journey. A truly fascinating aspect of our early development is that while the initial limb skeleton forms from somatic mesoderm condensations, during mid-development, the entire embryonic lower limb has to physically rotate 90 degrees medially. This massive rotation is exactly why your knees face forward and your big toe is on the medial side, which is the complete opposite of your upper limbs where your elbows face backward. Then, by week 8, a programmed cell death process called apoptosis neatly separates those blocky limb buds into your distinct, individual toes. To close out this explainer, I want to leave you with a fascinating clinical thought to ponder. We briefly mentioned hallux valgus earlier, which is a structural lateral deviation of the big toe, often associated with a bunion. If this foundational joint at the very bottom of your foot shifts, completely altering your medial arch and gait, how might this biomechanically chain react all the way up the leg? Could a simple issue in the big toe completely destabilize your knee, your hip, or even your spine? In the human body, absolutely everything is connected. Keep exploring those connections, and thank you so much for joining me on this topicological journey.